Hello and welcome to the Retina Radar. I'm Arshad Khanani, Managing Partner, Director of Clinical Research and Director of Fellowship at CRI Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. Today, I've been joined by my friend and colleague, Dr. Peter Campochiaro, Professor of Ophthalmology and Neuroscience at the Wilmer Eye Institute of Johns Hopkins University School of Medicine in Baltimore, Maryland. Welcome, Peter.
It's great to be here.
Today, we'll be discussing the benefits and limitations of sustained delivery systems in the treatment of retinal diseases. Peter, in this podcast, usually we dive into the topic, we ask some personal questions so that the audience can get to know you a little bit better. You know, you're a legend in the field. You've been an innovator for such a long time and have made significant contributions. But sometimes the audience wants to know a little bit more details about you. So first, we'll start with a few questions. So the first one is, how did you end up doing Retina?
Well, I was interested in neuroscience research, and so it came down to either neurology or neuro-ophthalmology or retina, and I felt that I might have a better impact clinically with retina, and I think I'm happy with my choice.
Oh, definitely should be happy you've contributed so much to the field and also for all the patients. You know, I think for the audience, everybody knows you, but not only you're a busy clinician, but you are a very heavy researcher doing a lot of early stage studies, which we will cover here later, especially gene therapy. In terms of how, Peter, tell us, what is your favorite hobby?
Well, I like to play tennis. Kind of keeps me active. I'm not a great tennis player, but I have fun with it.
Tennis, yeah, that's great. I mean, it's a good cardiovascular exercise and it's competitive, right? All of us tend to be competitive. So what happens? You end up losing or winning most of the time?
Well, splitting.
And who are you playing with?
I actually play with one of my medical school colleagues and then some other friends.
Great. That is exciting. And in terms of vacation, what is your favorite vacation spot?
Italy.
Italy, wow, that's been consistent with many of our faculty. So great. That's good to know. I didn't know that you love tennis. So hopefully we get to play tennis in Italy one of these days. I'm no good either, but I think I can learn from you. Okay, so let's dive into some of the sustained delivery topics here. I know you were very involved with sustained delivery steroid implants. I think as a field, when we think about sustained delivery, sometimes we don't even put plans that are currently approved for the management of diabetic macular edema. And I know you were lead author on many of those papers. So steroid implants, tell us where they bring the value and if you are using them before we dive into the ongoing trials on many of other modalities.
Yeah, I think they definitely have a role. I think that the fluocinolone implant, lasts for up to 3 years. And so in patients, particularly those that are pseudophakic and do not get an increase in intraocular pressure related to steroids, I think they can be very helpful in diabetic macular edema or retinal vein occlusion. And the dexamethasone implant, of course, lasts a much shorter period of time. It was originally the studies were for 6 months. I think it's more like 3 months that you get good activity, but it can be very useful in patients, who have macular edema for a variety of reasons. It could be DME, it could be vein occlusions or ocular inflammatory disease. I find it very useful for them.
No, I agree with you. I think they clearly have a role. Obviously, second line treatment, as you said, based on, risk benefit profile, IOP increase and cataract. But yeah, I mean, I think I use both of these routinely in patients, obviously if they fail other options or patients who cannot get frequent anti-VEGF injections. So let's dive into sustained delivery. So obviously you're involved with the steroid implants and you're a big fan of sustained delivery of anti-VEGF. Tell us, why should we look at sustained delivery of anti-VEGF? I mean, what is the value that we are looking at for physicians and patients?
Well, Arshad, in patients with neovascular AMD or diabetic macular edema or retinal vein occlusion, when they participate in clinical trials and get VEGF injections, their outcomes are very good. They have an initial substantial improvement in vision, and most times that vision is maintained and exudation is controlled. But when those same groups of patients are treated in clinical practice, the outcomes are not nearly as good. They often get a good improvement in vision initially, but then gradually lose vision over time. And one of the problems is that the frequent visits and injections are a big burden for patients. In clinical trials, we provide, the ability to have transportation to the clinic, and we make sure patients get there. But in clinical practice, it's a burden. So patients sometimes miss visits. And when they miss a visit, they get recurrences. And with some recurrences, you not only get exudation, but you get some onset of subretinal fibrosis. And that can lead to permanent reduction in vision. So with multiple recurrences over time, you gradually get reduction in vision. And with sustained delivery of anti-VEGFs, the burden is less, so compliance is better, the coverage is good, and so there's less likelihood of recurrences and development of subretinal fibrosis. So that's one big benefit. Another benefit is it removes some of the guesswork in our management. With treat and extend, we try to predict that interval between injections where the patient will not have a recurrence, but sometimes disease activity can increase. And then, an interval that was good for a patient previously might not be good, and then they come back with recurrences. And that same cycle can occur with, multiple recurrences over time, gradual development of subretinal fibrosis, and decreased vision. So I think that there's really good rationale for sustained delivery of anti-VEGF agents.
No, I totally agree with you. I think some of the reasons you mentioned obviously are super important because, as you said, even in trials, right? Like sometimes we see patients lose vision, and I think part of it is that we're not giving them, steady level of anti-VEGF, and there's CST fluctuations and there's disease recurrences that can cause that. So I agree with you. I think I'm a big fan of in delivery also. The question is, how do we get there safely, right? So we have obviously studied the port delivery system almost for the last decade, and you've been closely involved with that, especially neovascular AMD, where it was approved and then taken off from the market voluntarily because of some issues with the septum dislodgement, and now they have updated technically the implant as well as the needle. So Peter, tell us a little bit about kind of like the broad or key takeaways for PDS for neovascular AMD, and also what are the changes that have been made to kind of bring it back in clinical trial?
Yeah, well, the port delivery system, as you know, our shot is a implantable, refillable reservoir that constantly releases ranibizumab into the vitreous cavity. And the pharmacokinetics show that with monthly exchanges every 6 months, essentially all patients have very good levels of ranibizumab at all times. So it's very reliable. And the Archway study compared the PDS to monthly injections in patients who were previously treated who had neovascular AMD. And because they were previously treated, their baseline vision was very good, 20/32. And at the month 40 primary endpoint, it was also 20/32 in the PDS arm and in the monthly injection arm. So the PDS maintained that good baseline vision very well, controlled exudation, and was non-inferior to monthly injections. And that was the basis for its approval. And then the interim analysis of the Portal long-term extension trial has shown that good baseline visual acuity is maintained for at least 4 years, which is really quite remarkable. And the safety has improved over time as surgical approaches have been modified. We've come to learn the importance of conjunctival closure, and with greater detail and attention to make sure that there's good conjunctival closure, there's been less conjunctival problems like retraction and erosion. And it's those conjunctival problems that led to endophthalmitis. So there's also been a reduction in endophthalmitis. And, this is particularly emphasized by the Pagoda and Pavilion trials, which we'll probably talk about in a minute, in DME and diabetic retinopathy, where there were no cases of endophthalmitis through the primary endpoint in those trials. Now, you mentioned the recall. That was because, as you mentioned, of septum dislodgement in some of the phase 3 implants. Patients who were in the phase 3 trial, the implant that they used in those trials. And because of that, they did the recall. And because with septum dislodgement, that's what reseals the implant after a refill exchange. And so when that septum dislodges, you can no longer do refill exchanges. Now, during the recall, they redesigned the PDS and they improved the adhesion between the septum and the overmold, so it doubled the bond strength. And then, as you mentioned, they also provided light lubrication to the refill needle. Then they did some in vitro testing to try to simulate the use in the clinic. And to do that, they took, some of the phase 3 implants and the updated implant, and they heated them, which ages them. And then they did repeated punctures with the refill exchange needle. And after 21 punctures, which essentially simulates 10 years of use in the clinic, there were no failures, no septum dislodgements in the updated implant, but there were many in those phase 3. So the improvements definitely have, made the PDS more reliable. And as of April of 2024, that testing is now up to 71 punctures, which simulates 32 years of use, and there were still no failures in the updated implant. So as you mentioned, it's now being used in clinical trials and should be available for clinical practice very soon.
That's a great summary, Peter. So I think few things that you highlighted are super important. I think number one, obviously the long-term interim portal data. I think when I saw that data, Peter, I was pretty impressed because we have not been able to show that even with the anti-VEGF studies, right? Because you go in, the 7F data and others, even CAT trial, right? You go into standard of care, patients get undertreated. Sometimes even in the studies, you see a decline in visual acuity in second year, right? When you start to become more flexible in terms of treating the patient. So yeah, that long-term maintenance of vision, I think that's something the field is looking for because we want to have the best outcomes for our patients. And I think the way to maximize outcomes is to give them maximum injections. And obviously that's not possible in a real world setting. So having PDS help with that is a great tool. And I think the technical details that you mentioned are pretty impressive. I think the audience will appreciate the understanding why it was recalled and what has been done. Because, when you take a product off the market, there's always people are more worried when it comes back. So it sounds like the way they have fixed the problem and they continue to generate the data, physicians should be more than comfortable that the septum dislodgement rate will be minimal or none, correct?
Correct.
So I think that's something to highlight. And then last thing is, you led the study that I was also lucky to be a part of and published in AJO about exudations and outcomes for the patients that were in the Archway study. Can you give us a little bit of summary of that?
We're accustomed to looking at the aggregate data in clinical trials. And of course, as you mentioned, the aggregate data are impressive because that baseline visual acuity is well maintained, even out to 4 years. But what about the individual patients? And that's what you and I looked at in that study. And what we saw was that, the vast majority of patients, once they get the PDS, they have very little recurrent fluid. But they occasionally have some. There's some patients who do. But the amazing thing is that they tolerate that very well, and it waxes and wanes so that, sometimes they'll get a little bit of fluid and then it'll go away. And, we mentioned about how recurrences can, be a problem because they can cause subretinal fibrosis. But in this case, that constant coverage with anti-VEGF seems to allow a little bit of exudation without any accompanying subretinal fibrosis. And that's one of the reasons why these patients tend to maintain good vision long term.
I think that's a very important point here, right? I think I think you have that level of confidence that you have the baseline anti-VEGF that is controlling the disease, so that I don't think we have to panic in terms of treating aggressively if you have a little bit of fluid that goes away over time. And I've seen that with other sustained delivery technologies also. So Peter, great overview of the AMD data for PDS. How about just a quick summary of the Pagoda DME trial and the Pavilion trial?
Sure, Arshad. In Pagoda, the eligible patients with DME were randomized 3-2 to the port delivery system versus monthly injections. And with the port delivery system, they were given 4 injections of ranibizumab, then had the PDS implant, and then refill exchanges every 6 months. And the adjusted mean best corrected visual acuity at weeks, averaged over weeks 60 to 64, that change from baseline was 9.6 letters in the PDS arm and 9.4 in the monthly injection arm. So again, the PDS was non-inferior, and it was very good at controlling exudation in DME. 95% of the patients in the PDS arm did not get any refill, not get any rescue injections. And as I mentioned before, there was no endophthalmitis and very few problems with conjunctival retraction or erosion. There was just one implant dislocation. So for DME, like with neovascular AMD, the PDS provided excellent control of the exudation and with very few complications. Now in Pavilion, 106 patients were randomized. They were patients with diabetic retinopathy severity scores of 47 or 43, and they were randomized to the PDS with refill exchanges every 36 weeks or observation. So there were 106 patients in the PDS arm and 68 in the observation arm. And at week 52, the percentage of patients that had 2 steps or more improvement in diabetic retinopathy severity score was 80% in the PDS arm and 9% in the observation arm. So, a really incredible number that had that improvement in retinopathy. But moreover, in the PDS arm, there was no worsening of retinal non-perfusion, and there was substantial worsening in the observation arm. And as you know, Arshad, worsening of non-perfusion leads to proliferative diabetic retinopathy and anterior segment neovascularization, which are vision-threatening complications. And in the observation arm, 42% of the patients had these vision-threatening complications, whereas none in the PDS arm. So in treating diabetic retinopathy, the PDS dramatically improves retinopathy, but it also prevents progression of retinal non-perfusion and prevents vision-threatening complications. So those are very impressive results.
No, I totally agree with you. I think it's the kind of results that give you a wow factor, obviously, right? And I think not having endophthalmitis shows that the learnings that have been implemented about the surgical technique has helped. But Peter, where do you think it fits in for DME and DR? Because obviously still a surgical procedure and this patient population is quite young. So do we worry about long-term issues with PDS in this patient population, or do you feel like the safety profile is very well tolerated? Because, the issue with diabetics is that they come to your clinic and then they disappear for years and then they come back blind. And I think with this, we'll be able to hopefully cut that down. But obviously, the risk is that it is an indwelling implant in the eye. What are your thoughts on that?
Yeah, I think you bring up good points, Arshad. We don't know. We do have now experience, going out to about 6 years, in the patients with neovascular AMD, and the implant is tolerated very well. But we don't know really long term. The one thing we do know, though, is that it is possible, if an implant fails, that you can replace it. That's one of the things that we learned with the septum dislodgement, is that that's how many investigators handled it. Once septum dislodgement occurred, they replaced it with another implant, and those cases have done very well. So I think it is a valid concern, in younger patients. But as you mentioned, having that less burden in patients who tend to be a little bit less compliant can be a really important factor. And what I've found with the diabetic patients is that, the ones who were in trials who had the implant in one eye really preferred it and tended to do better in that eye than the other eye. And so I think that there's still a little bit of unknowns, but I think it is a good option for patients with DME and severe non-proliferative diabetic retinopathy.
No, I agree with you. I think the one thing that doesn't get translated into the data that we present on the podium is patient experience, right? These patients are super happy. They come in happy because they know they're not going to get an injection. And I've done many fellow eye implants when PDS was available commercially because patients were receiving frequent injections in their fellow eye and they wanted to get the implant. So I think that just kind of shows us that the patient satisfaction obviously is very high with this. And I think if the surgery is done properly and risk and benefits are discussed with the patient, then I think it's a good option. Obviously, it's not going to take anti-VEGF injections away because that's how we start. But I think for a subset of patients, this may be a really good way to control their disease and maintain long-term vision. So moving on, Peter, obviously after PDS, we have gene therapies, we have tyrosine kinase inhibitors, but we don't have time to discuss all. So let's focus on gene therapies. And I know you were very closely involved with the preclinical, experiments with ABBV RGX 314. So just tell us a little bit about subretinal gene therapy in terms of controlling neovascular AMD and also suprachoroidal gene therapy for neovascular AMD and DR. What are your thoughts and some of the key learnings that we have seen so far?
Yeah, well, Arshad, gene therapy provides another way for sustained delivery. It's just that it's done by transfecting retinal cells that then can constantly produce the anti-VEGF protein. And as you mentioned, there's three routes of delivery that are being tested: subretinal, suprachoroidal, and intravitreal. And the subretinal injection of RGX-314 is the one that's furthest along in development. And RGX-314 is an AAV8 vector that expresses an anti-VEGF antibody fragment similar to ranibizumab. And a phase 1/2A trial has been completed in which 42 patients were involved with 5 dose cohorts, and they were followed for 2 years. And the safety was quite good, but there was one drug-related SAE. It occurred 12 months after subretinal injection of 2E11, the highest dose, and it resulted in pigmentary changes of the macula and a substantial reduction in vision. Now, there weren't any SAEs in the lower dose cohorts, but there was some pigmentary changes in the inferior retina. Some hyperpigmentation and hypopigmentation hasn't affected vision. Patients are not symptomatic from it, but we really don't understand the mechanism. And, so that's something that's, being closely followed. Now, with doses of 6E10 or greater, there was good expression of RGX-314 protein through 2 years, which was the longest time point that was measured. And in cohorts 3 and 4, 3 got the 6E10, 4 got 1E11. The mean best corrected visual acuity was stable or improved at 2 years. And many of the patients had either no or few rescue injections. That didn't apply to all. Some patients still required rescue injections. But, a substantial number did very well with control of exudation. And so doses similar to the 6E10 and 1E11 are now being tested in phase 3 trials.
Yeah, no, I mean, I think it's very exciting, right? It's one-time gene therapy, obviously done in the operating room in pseudophakic patients, but the data is impressive. Again, sustained delivery, controlling the disease, and I think that's going to modify the outcomes. The pigmentary change is interesting, right? So from phase 1/2 to now in pivotals, we have moved the bleb from superior to inferior, and I think that kind of has decrease the risk of vision loss by having the gene product go into the macula, right? Because we are now injecting inferiorly.
Yeah.
So I think that should take care of the pigmentary changes. But yeah, it's intriguing what is causing it, because those areas are still producing good amount of protein, as you said, because the levels of protein are being maintained. If you look at the long-term extension, even from the phase 1, 2 patients, right?
Yes, that's right.
So what about suprachoroidal, Peter, in terms of RGX-314 is in clinic, obviously we'll be able to, treat a larger number of patients so that we don't have to go to the OR. You can treat phakic patients with it. I think the data from neovascular AMD and DR, to me, shows biological activity through suprachoroidal space administration. But in terms of DR, I think that's very interesting personally for me, because it's a disease where we are not treating, and these patients are getting worse over time or disappearing, as we discussed. And having a one-time gene therapy in clinic for DR, that seems very promising if we can pan it out. So can you briefly just cover that for us?
Sure. Yeah, as you mentioned in diabetic retinopathy, the altitude study used the first two cohorts got 2.5 E11 of RGX-314 by suprachoroidal injection, and the second cohort 5 E11. And what it showed was that, first of all, there were very few patients in the first cohort, so there's not very meaningful data there. But the second cohort had 24 patients, so it's a fair number of patients. And at 1 year in that cohort, 21% had two-step improvement or more. Only one patient did in a control group. 70% showed at least some improvement, one or two-step improvement, and none of the patients had any worsening. And that's versus 38% in the control group that showed worsening of retinopathy. And 4% of the patients in the RGX-314 group developed vision-threatening complications versus 38% in the controls. So I agree with you. It's encouraging results with a in-clinic treatment. They're now investigating a higher dose of 1E12 with steroid prophylaxis, and they're now planning a phase 3 trial. So this is something that's moving along. With the neovascular AMD, the AVIATE trial, again, the first two cohorts were similar, 2.5E11 and 5E11. They saw mild inflammation in 30% of the patients, either episcleritis or some intraocular inflammation. It was well controlled with topical steroids and resolved, didn't recur after the steroids were tapered. And these patients in both cohorts showed stable or improved best corrected visual acuity at 6 months. And 28% in the first cohort didn't require any rescue injections, and 40% in the second cohort. And again, in this trial, they're now testing the 1E12, a higher dose by suprachoroidal injection with steroid prophylaxis. So I think you're right. It shows biological activity. It's not all patients that receive the treatment, but a substantial number get good control of exudation without any additional injections. And so it's encouraging, and we look forward to seeing the higher dose cohorts.
No, I agree with you. I think continue to look for the risk benefit with higher dose, and also making sure that the safety doesn't get worse. And so I think an in-clinic gene therapy obviously holds the potential in terms of treating a larger number of patients. But I think getting the subretinal gene therapy approved will be a good thing for the field, because I think you can still have it for a subset of patients, because we are enrolling in the phase 3 subretinal gene therapy program, and there's a lot of interest from the patient in terms of participating in those trials, because they want to make sure that they are not getting repeated injections. So Peter, just a quick overview in terms of intravitreal gene therapy. We have 4D150, which carries a dual transgene of aflibercept as well as interference mRNA for VEGF-C, and then we have Exovac or ADVM022, which is carries a transgene for aflibercept. And both of these vectors have gone through directed evolution, so they can penetrate the ILM And we have seen promising results from both programs. Obviously, the safety has been an issue, especially with Exovac, where we had hypotony and choroidal effusions in the DME trial that was not seen in the optic study. So they have gone into, the phase 2 Luna study, where the interim data will be released in the near future in terms of different, steroid regimen to see if we can control inflammation. And then 4D-150, obviously, I presented the data at angiogenesis this year in terms of reduction in treatment burden and disease control. I think the main thing here was the safety looked very, very good in terms of not having recurrent inflammation over time, and then significant reduction in treatment burden, between 80 to 90%, I think, showing biological activity. I mean, one thing to highlight was that study, the phase 2, portion of the PRISM study, the initial cohort has been looking at, high treatment burden and severe patients, and having biological activity in those patient population clearly established the fact that we have something in terms of controlling disease. So any quick thoughts on intravitreal gene therapies, Peter?
No, I think you summarized it well. They really look quite promising. As you mentioned, in the Luna study with the steroid prophylaxis, now it was pretty substantial prophylaxis. They split it up between oral prednisone versus topical steroids combined with injection of a dexamethasone implant. So they prophylaxed for all 26 weeks, but at 26 weeks, there really wasn't much sign of inflammation and good control of exudation. And they report in the low dose, the 60-10, 69% of the patients did not require a rescue. And in the higher dose, 85% did not. So that's pretty encouraging. And, similar encouraging results in the PRISM study with the 4D-150, as you mentioned, at 6 months, 50% in the lower dose, no rescue injections, and 60% in the higher dose. So, there's still, some patients with previously treated neovascular AMD who may not be completely responsive to anti-VEGF treatment. And with these treatments, they might not be ideal candidates, but for the vast majority, these treatments look very promising.
No, I agree with you. I think, and for me that, for the 4D-150, the 89% overall reduction in treatment burden on these patients who actually received around 10 injections, so actual injections. And I think the other benefit was the fluctuations, if we can have sustained delivery intravitreally or subretinally or suprachoroidally, having that fluctuations we were talking about where we get a steady state. I think in the PRISM study, we were able to see much better control with 4D compared to the aflibercept control. So no, very exciting times for gene therapy, Peter. We're running out of time, so just kind of a couple of questions again about yourself. What is the career achievement you're most proud of?
Well, I think that the greatest satisfaction I get is from patients. I think we're very privileged in our profession to be able to take care of patients and to many times see them get improved vision. And I think that's what probably drives most of us. And I think it's something that, has really made me enjoy this career in ophthalmology.
No, that's very nice to hear. I think the patient focus attitude is the way to go. And I think, you mentioned that, or many awards you have won, you're world renowned, you have done so many publications, you have trained so many fellows and made such an impact. So I think one thing I learned from you is always think about the patient that's sitting in front of you and doing the best to preserve or improve their visual acuity. And then the last one, Peter, I know you still got many more years to go. How do you want to be remembered once you retire?
Well, one thing is, as your friend, I think that, working with colleagues like you has really enhanced the sort of profession that we have. That, and, as I mentioned, the patients and anything that we can do to ease the burden of visual disability in patients, I think, is worthwhile. And so I think we're very fortunate to be in the profession that we are.
No, I totally agree with you. And obviously you have made huge impacts in that area, being involved with, many of the drugs in the past, and the drugs that are approved, as well as all the new treatments we are looking at, including port delivery system and gene therapy. So thank you again, Peter, for being here with us for the excellent discussion. And I want to thank the audience for listening in. Please remember to take the post-test and evaluation to receive CME credit, and to tune in for additional episodes within the podcast series. Thank you again, Peter.